Welcome to the Business of Medicine podcast from the Southern Medical Association. Since 1906, SMA has had a singular mission to provide medical professionals with the resources they need to learn from each other and in doing so, improve the overall quality of patient care. The Business of Medicine podcast is dedicated to exploring and simplifying the varied and complex business aspects of running a medical practice so that you can do what you do best, provide your patients with the highest possible standard of care. To learn more about SMA's many other services and educational initiatives, please visit us at sma.org.
Hello, everyone, and welcome to the latest episode of The Business of Medicine, one of the podcasts brought to you by the Southern Medical Association. My name is Christine McEvoy, and I'm the Communications Chair for the Physicians in Training Leadership Committee. I'm joined today by Dr. Paul Hubbell, who is an anesthesiologist in the greater New Orleans area, to talk a little bit about his path to his pain management practice and what tips he may have for anyone ranging from still in their training to starting off on their own to maybe wanting to have a little bit of a career change up on the entrepreneurial side when it comes to practice management. So thank you for joining us, Dr. Hubbell.
Thank you. It's very nice to be with you.
Great. So how about we start off by just having you tell us a little bit about your path to your current career in pain management, because it's actually a very unique one.
Yeah, mine's a little different. I never dreamed I'd be a physician. Actually left college playing. I was actually playing football in college and with a scholarship, and got a fractured C6 vertebra in an auto accident. So I really couldn't continue. So I finished in about 3 years looking for going to dental school. I went to dental school, finished, and started practicing in a general dentistry practice for 3 years. Well, at the probably close to the end of the second year, I was in an automobile accident with someone else driving that wound up causing 2 herniated lumbar discs and a fractured vertebra that prevented me from sitting and bending forward. And dentists actually lean forward and twist instead of sitting up straight. So that caused significant radicular pain. Although I did never get surgery, because what I was told was take off 8 weeks and see how much position was aggravating pain. Well, I didn't hardly have any pain unless I did something very strenuous. So I started looking for, what do you do when you've had all this education in a very narrow window of all the things you could be educated in? And, do you do medical sales? Do you do something else in medicine or something completely different? Well, 2 things to note. One is it's very important as a young doctor to buy disability insurance. And especially if you can get it today in your own specialty or your own field of practice, because that can help bridge you into something else should something happen. Second, I was actually reading the American Dental Association Journal and saw that you could become an anesthesiologist as a dentist. There's about 250 dentists in the nation who are completed in anesthesiology residence with medical graduates. So I actually entered Boston University combined program with Boston City Hospital anesthesiology residency. And after completing that residency, became a clinical instructor of anesthesiology at Boston University, until I realized that for long term, it might be better for security to have a medical degree. So one day I was the director of the surgical ICU and teaching anesthesia in the OR, and the next day I was a third-year med student.
Wow, that's quite a change.
Yeah. So and I was probably older than many of my consultants.
I'm sure.
But at any rate, I did that in order to become board certified, because in the middle of my residency, the ASA made a rule that said you had to complete med school before you did your residency, because a number of dentists were sitting for the boards and passing, and they wanted to control who was able to take the test. So I did a year of surgery after med school at a VA, and then did a residency again with a flair for pain management at Mayo Clinic. That way, I was at the Knife and Gun Club in Boston, and now I could go to see esoteric cases at Mayo. And did about 13 out of the 36 months was in pain management. So I then started practicing after that, but kind of a circuitous route. But you got to have stick-to-itiveness, and you got to be open to other ways to be happy in life. But make sure you get disability policy and don't turn down increases when you deserve them, because it's especially at a young age, because it could help you for quite a long time.
That is a very important piece of advice that I think not a lot of students at my point in their career, many of whom are in their 20s, really think about. But it can be really critical and life changing in terms of what are you going to do after you've invested all this time and money. And I'm glad to see that you are still doing okay to this day. Those are quite a string of traumatic accidents.
Yeah, you know what's interesting, one other point that'll make the point. Coming out of school, they offer you like $2,000 or $3,000 a month of tax-free income with a disability policy. 2 weeks before I had that last auto accident, I was offered $12,000 a month, and I turned it down because I said, I'm young, I'm not going to get hurt, I'll live forever. I don't need to worry about this right now. I need it when I'm older. So that was a big difference in what I was going to be able to do in my life, because $12,000 tax-free is a lot different than $2,000.
Very much so. Tell us a little bit too about your career in the military as well, coinciding with all these changes in career and navigating those challenges.
Sure. Because I was an older student, and because my wife and I were married for about 14 years and before we had a child, now I was a first-year anesthesia resident, and my son was born. And I decided I would rather use my time wisely, be able to spend time with my son, since that may be the only child that we have, which it was. And so I didn't want to moonlight. I wanted to have a way to make some money so that we could live as a resident. So I had been in the Marine Junior ROTC in high school, and so I joined the Army National Guard. And at the time, they had a plan where they were trying to encourage anesthesiologists and surgeons into the Army Reserves or National Guard, because they were short in the active duty. They offered you a plan called the Strap Plan, which they paid you like $800 a month, and then you also could make drill pay per month, couple of $300, I think. So that was a nice source of revenue. And drill was not necessarily every month for medical students, and then as an intern certainly wasn't every month, but they allowed you to do journal clubs and read articles and things that would pertain to your practice to make up that time and still get paid. So that helped to get me started. But then I was able to utilize, because I was at a VA, I was able to utilize 2 weeks of paid time off from the VA while going to my Officer Basic course. And the VA still paid me while I was gone, which was nice. So I got paid by the Army and the VA. And then later, did the same thing with the Officer Advanced course. And so I got my military education, in which many doctors don't do. They just focus on reasonably on their medical practice. So once I did that, eventually I continued my medical education my military education, by completing Command and General Staff School. And once you've been mobilized and you have that, it makes you very competitive and kind of singles you out for promotion to colonel or general. And actually, I did get mobilized to Landstuhl, Germany at the beginning of the Second Gulf War of 2003. And after I came back, I had the Command and General Staff School completed, and I was given a letter to say, hey, please submit your packet for 07. But if you accept that as a reservist, you basically are gone 6 months from your practice, not all at once, but intermittently, flying all over the world for meetings. And that probably was about 10 years too early for me to be retiring. So
and for those of us who are listening who might not be familiar with what 07 means, that is the rank of a 1-star general in the military.
Yes.
Wow. Well, thank you for sharing that with us. Now let's kind of fast forward to present day. What does a typical day look like in your practice and a typical week?
Well, now I practice nearly 99.9% interventional pain. So I got real interested in pain based on my history with experiencing 2 different types of pain accidents, and also in experiencing people's reaction to people like myself who were hurt. And they basically, if you didn't walk around with a frown on your face, they didn't believe you were injured. And so they didn't understand why your life would be different. And so while I was at Boston as a resident, one of the staff and myself started an RSD clinic, reflex sympathetic dystrophy clinic, because we had a patient who had stepped on a rusty long nail and had 6 or 7 kids and was begging to get back to work so he could support them. But he had this red, hot, beefy, very painful foot. He couldn't walk, couldn't put weight bear. So we did multiple injections, including guanethidine, beer blocks, and other things in beer blocks, regular beer blocks, and actually got him in physical therapy, and he actually returned to work. So that was something we saw as a benefit that we could use later on. And so we started getting more and more referrals for that kind of work. And that was in the early 80s, and we didn't have epidural injections, facet injections, even sacroiliac joint injections. We weren't really, anesthesia and medicine wasn't really offering that as a method of treatment. In fact, I think epidural blood patches started right around that time. So it was at the infancy of pain. And so when I got into residency the second time, I was able to focus on that specialty of interventional pain. So today, what I do is do injections for diagnosis of problems, hopefully to provide therapeutics at the same time, but if not, at least understand the cause of pain. So I'm focused daily on how do I determine what's causing the pain, and then what do I do to help reduce it or eliminate it? And that can be anywhere from injections to implanting spinal cord stimulators or intrathecal catheter and continuous pump under the skin. It could be placing an interspinous spacer for stenosis, which gives many Medicare patients or Medicare age patients a new quality of life, so they can walk and stand now and not limited, which keeps them alive longer. Also, we can do a sacroiliac joint fusion, which is basically placing a piece of demineralized bone in between the sacrum and the iliac, which stops the compression of that tissue and also stops the bones from impinging on one another, and that takes away people's pain. It's amazing, almost immediately.
Wow. So tell us a little bit more on the structure of your practice, how many clinics you work in, what your ownership is of those clinics and or operating or outpatient surgery centers, and what does that week look like in terms of hopping from one location to another?
Yeah, I don't like to be in one place for too long. I like change every day. So, and patients that I have in New Orleans area, the Mississippi River runs right through the middle of the city, and you would swear that people on one bank think that the other bank's in California. They don't want to cross the river, and so they like to stay around their homes and not travel. And then there's a lake that's 24 miles wide, so those people on the other side of the lake don't want to cross the lake unless they have to. So I have a practice on the north side of New Orleans. It's 20-30 miles away from New Orleans across the lake. Another one across the river, which is probably about 10 miles. And so I have 3, one in Metairie, one in the west bank of New Orleans, and one in Covington, which is north of New Orleans. And so I go every morning from about 7:30 till noon, I'm going to be doing procedures at one of 4 facilities. And every afternoon, I'm in the clinic seeing patients, except Friday afternoon, which I don't. I just leave that for doing things that I need to catch up on during the week. So I've got a lot of variety. Though each location has a different type of patient on the whole. So it's a nice variety. So basically, I'm moving every day. I'm moving from one location in the morning to the either the Metairie office or the Covington office or the West Bank office in the afternoon.
Wow, definitely a busy week, but lots of variety and patience in each location, it sounds like. In your career so far, and this can be at any point in your career, what do you think was the most important decision you've ever made, business-wise?
Business-wise, the biggest scare that physicians have, and I guess it was different for me because I was a dentist first, but for physicians, when you're really well educated on medical science, but not very well educated on business. So doctors make a decision to become employed because it's a guaranteed check, but they don't realize that with the check comes the boss telling you what to do. And that may be that's more likely than not a businessman boss that tells you what to do. And so you may not be practicing the kind of medicine that you want to, but you bargain with yourself to accept that problem as long as you can get this guaranteed income. And I think today is becoming more and more like that for the new graduate. Many of the new graduates are just believing that that's the only way they need to go. And with me, I was in dental school. Luckily, we had about 6 months of business education trying to teach us how to balance books, how to do accounts receivable, what was involved with getting procedures approved. And today, that's a really big part of the practice is the person who's going to evaluate the insurance plan, communicate with the insurance plan and the patient, and get the procedure approved, meaning follow the rules of each individual insurance company. That is going to determine whether you're going to work or not. When you work for someone, they have the duty of doing that. And so you're not as involved, I would say. But it's important if you're on a quota system, if you will, or if you want to make a bonus, you have to know when your treatment plan, what things will get approved and which ones won't, so that you don't have a backlog of people being seen but not being treated. And so those patients don't have any outcomes to measure because you're not able to do anything. So in dentistry, I basically took every benefit book. I made patients bring in their benefit book for each dental plan. And when I treatment planned them, I looked through their plan and figured out what could be paid and what couldn't, so that they weren't strapped with costs they couldn't afford, and that we could get what they needed done as much as possible using the plan. In medicine, I don't think docs do that very much. I don't think you're taught to do that. That's far from anything that you're going to experience in your residency, I can assure you. So it's important to understand business. It's also important to understand that when you walk out with a medical degree in a residency, that most any bank worth its weight in gold is going to give you a line of credit. And most docs are very afraid of signing that note. But they give you that because they know your income earning potential is such that you can surely afford to pay it back. But when you're a new graduate and looking at a $125,000 loan, you're also looking at paying off student loans. You're looking at a house note, a car, family. So the amount of debt coming out of school is so high, it really frightens new grads. And I think that's partially why they accept a known check from someone. But as you grow through your experience, many people will decide that they can do it better themselves, or they feel like they could be more productive, or they want to be just able to make decisions medically that they feel is the best for the patient. So that's when you're going to have the tough decision about going out, making a hard business decision of, okay, I got to go to the bank, I got to get a pro forma. And so, meaning that's a plan for how your business is what it's supposed to cost each month for a year. And that pro forma, that kind of thing is going to mean you're going to need to hire someone who's got that kind of business experience to work with you to help plan this transition. A lot of times banks will offer you that, but that's a hard decision, is when you have these loans outstanding and you have to take out another one to open a practice.
Very interesting and very detailed and informative. I think that will be very helpful information for trainees to hear, and new doctors as well. What are some of the biggest challenges that you're facing currently running your practice?
Oh, the biggest challenges are reimbursements are decreasing daily. hurdles are being placed in our way that interrupt the patient's ability to get the care they need. Yet you're looking them in the eye and you know you can help them and they can't afford to do it on their own. And the insurer they have is not providing the care. And the insurers simply can use and have been successfully using the phrase that, well, that's an experimental treatment. Whether it is or not, in the true definition, it could be a treatment that's already been vetted and proven to be safe by Medicare and CMS, but the private insurers will claim, oh, that's an experimental treatment, yet it can provide great outcomes. So that challenges the money. The money is not increasing, but decreasing. The nice part, the other side of that coin is there are procedures that have been introduced in interventional pain that allow us to, and that are paid for now, that allow us to make a drastic change in the quality of life of patients. And so, and they're paying for those, and hopefully the insurers are getting smart to realize that if we do some of these procedures, patients stop utilizing medical care, that they actually get a better quality of life and become healthier because now they can be active.
What advice do you have? I know you've already given quite a bit during this chat, but what parting advice might you have for trainees who might be thinking about their first career moves or those looking to make a change and delve more into the business side of medicine?
Yeah, well, you look, getting out of residency and becoming an attending is a nice way to gather more experience because, you know, this is an art as much as it's a science, this practice of medicine. You don't even come close to seeing and doing everything that can be seen and done in a medical practice in the field you're practicing in. So the more you see, the better you become prepared to be able to make decisions, because it's the same in dentistry. I mean, they teach you certain things and it sounds like they babyifying the presentation, making you do step by step learning of how to accomplish something when you can maybe do it in 2 steps. But the reason that's being done that way is so that you can use your clinical judgment later in life and pick up at any one of those points in the steps and realize, oh, if I do this, then I do that. So it teaches you how to critically think on things that you hadn't seen before. And, I guess one of the things that's most important about the future is that you can't ever stop reading. You got to constantly research things that come up that you're not sure about, you don't remember, or that have changed, and incorporate that into your practice to be able to deliver the best quality and the most efficiently. So the business side of medicine, and no matter if it's pain or any other specialty, it's basically what I mentioned before. You have to be able to generate enough revenue to pay the people that are going to be helping you to run the office. In today's world, more than ever, the articles that are being written show that we need ancillary personnel more than we ever did before. There's maybe up to 2 to 3 people extra that are needed now in the office to manage the billing and collecting, the insurance approvals, pre-authorization as they call it. So you have to be able to pay a number of people and yourself, and then have some money to invest in, new findings, new pieces of equipment that could help you to make more money. So it's going to be, to make this business decision, you're going to have to find some kind of a mentor or some type of business person who can help you to accomplish these goals. And you can pay them by the hour, you can pay them by the task.
Well, thank you so much for taking the time to talk with me today, Dr. Hubbell, and thank you for joining us. This is Business of Medicine podcast, and we just finished chatting with Dr. Paul Hubbell, who works in pain management in the greater New Orleans area. He's also not only a doctor of anesthesia, but also a doctor working in anesthesia, but also a dentist, a retired Army colonel, and has a lot of unique insight that I hope that everybody has enjoyed listening to as much as I have today. Thank you.
Thank you. Can I say one more thing for you?
Yes, sir, you can.
I'm on an interprofessional committee between the Louisiana Bar Association and the Medical Association. That's designed to help doctors and physicians doctors and lawyers, get along better. And one of the things we do is we put together a program at the end of each year where we invite the medical students that are graduating to come and listen to the kinds of questions and things you talked about, business, but also about depositions and lawyers and subpoenas and things that you may not know about. So I recommend when you see it at your school, it's at the end of the year and maybe you're a senior and you think you've finished school, but it's really important to try to listen to that. And I do believe they make it available for you in like a podcast setting. So in case if you're busy, you can't make it at the time it's presented, but it's very informative and it answers many of the questions you were asking today.
Well, thank you so much. I will definitely be on the lookout for that as I head toward the end of medical school, even though I've still got about 9 months to go, but that'll definitely be an important talk to seek out as I finish up my med school training. Thank you so much, Dr. Hubbell, and I hope you have a good rest of your weekend.
Thank you. It was very nice to be with you.
We hope you enjoyed the Business of Medicine. For more episodes in this series or SMA's The Practice of Medicine podcast, go to sma.org/podcasts or subscribe to us on iTunes, Google Play, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit us at sma.org, and thank you for joining us.